Good afternoon and welcome to the Insights in AI virtual series. My name is Sohail Khan, and on behalf of the RapidAI team, we want to thank you for joining us. It is an honor to have Dr. Harmeet Sachdev here to share his key lessons from the real-world evaluation of AI stroke technology. At any time during the presentation, we encourage you to submit your questions in the Q&A box on your screen. Dr. Sachdev is a board-certified neurologist specializing in stroke and neurovascular care. As the medical director of stroke and neurovascular services at Good Samaritan Hospital in San Jose, he focuses on advancing acute stroke care through innovative technologies and evidence-based practices. Dr. Sachdev remains active in research on stroke systems of care and the role of AI in neurovascular treatment. He is also a fellow of the American Academy of Neurology and member of the American Heart Association, AHA Stroke Council, and Neurocritical Care Society. With that, I will turn the floor over to Dr. Sachdev.
Thank you, Sohail. Welcome, ladies and gentlemen. Well, we're talking about the AI tools needed to be trusted. Well, we are all stroke doctors. We know what we do. And time is brain. And Patrick Lydon, my mentor sort of way and colleague, we started doing TPS together years ago. He used to say, and he still says, that we stroke docs live by clock. The time is brain. Every minute counts. So making a correct diagnosis at the correct time and taking the correct patient for the correct treatment is the thing to do. And that's what we do. So a patient who's lying on the gurney, you are coming to the ED, and whatever we do with the help of AI or without AI in the past is to have this patient with horizontal lying on the gurney. If that patient is to walk or even run out of the hospital, that makes my day. I'm sure you feel the same way. Now, Good Samaritan Hospital. So let me talk about a little bit how it happened. I'm a neurologist, a simple neurologist, in private practice, solo. And in 1996, on July 1st, day after the FDA approved TPA for stroke treatment, acute ischemic stroke, I had just come back from UCLA brain attack meeting headed by Jeff Saver and Sidney Stockman. And I find this 49-year-old person lying on the gurney. He was a husband of a nurse who used to work in the hospital at Good Sam in San Jose, and completely paralyzed on the right side of his body, nothing, loss of speech, and almost 80 minutes into what he came from the time of onset. There was no concept of stroke team or anything at that time. And that was my very first patient we did. And later on, I realized that we were one of the first community hospitals in the state of California to do the intravenous TPA. And I think it was a timing issue. The patient recovered. And that changed my life as a stroke doctor, from clinical practice, just going most of time doing the stroke medicine. So this resulted into our becoming a primary stroke center, among the first 5 in the nation back in 2003. Then our hospital was taken over by HCA. And Dr. Reza Malik is our NIR physician. He joined our staff, and we were part of Multi Mercy. We started pulling clots out even going back to 2010. And in 2010, Sam Hazen, who is now the CEO of HCA, he was at a lower level in the administrative, tandem pole. And he saw what we were doing, and he was impressed. And he blessed us, or I will say he blessed the city of San Jose with biplane imaging. And this resulted into our becoming a comprehensive stroke center, one of the first community hospital in state of California to become a comprehensive stroke center back in 2012. Well, San Jose is a very large city, over 1 million people. We are 474, beds, 51,000 ED visits a year. We have been doing more than 800 cold strokes a year. And to be on the roll for Get With Guidelines, Gold Plus, door to needle time, in 92% of the cases, less than 45 minutes. And that's the way to really do the stroke medicines. And this is just to share data from our community hospital, And back in 2024, actually, we had more than 1,400 stroke alerts. We've been very, very busy. And out of that, 43% of those stroke alerts were confirmed stroke cases. And our fastest door to needle time was 13 minutes. And our fastest door to groin time was 55 minutes. And in 2025, through March, This year, our door to needle time is running like 90 minutes. And we done some of the door to groin time in 60 minutes. And I'll show you, how we are able to do that. It's not easy. So going to the basic stroke care here, okay, that this is your patient or my patient, could be anybody's patient. This 64-year-old man, he presented at a spoke hospital, referred the patient to us with the left MCA, LIC occlusion, right facial droop, aphasia, complete weakness of the right upper extremity, mild to moderate stroke with an stroke scale of 8. And this spoke hospital also has, RapidAI available. They do CT imaging and all that. And of course, he received the TNK right away. And then the patient was referred to us immediately. As soon as the patient came to us, we have 3 CT scanners in our community hospital. One is stationed right across the ambulance bay in the ED itself. So as soon as we did the first CT and there was no ICH conversion or any infarct showing up, the patient was taken to the cath lab right away. Door to groin time was 24 minutes. And recanalization was pretty good. TK2C could be better. And patient had NI stroke scale of 1. And we did an MRI scan. There was a small DWI positive area right there. He had some word finding difficulty when he left. But later on, when he was followed up in my office in few weeks, the speech was completely normal. Now, not all the things happen correctly, even though we are a very well-oiled machine and we do so many patients. We have telestroke team. We have the SWAT team, as we call, for our well-trained stroke nurses in the ED. The things sometimes do not go the way you want to. This is an example of a 63-year-old man who had, right hemispheric stroke with left-sided hemiplegia and moderate stroke, NI stroke scale 13. And we found that he had M1 occlusion. The telestroke docs were working on this patient. The family was not available. So door to TNK time was 57 minutes, which is not acceptable. Okay. And then moreover, when we did the CT perfusion on the rapid imaging, you could see the bolus was not right. So our radiologist has to go source by source images to really tell us the truth. And you could see the CT perfusion showed a fairly large penumbra. So door to groin time again increased to 120 minutes. I mean, this was not a good day in our ED or even cath lab. Let's put it this way. And door to groin time of 120 minutes is not acceptable. It has to be, by the rule of get with guidelines, less than 90 minutes. So we were still able to get TK2C perfusion, but the patient did not do well. And you could see on the CT scan next day, he was showing an early infarct and patient went to nursing home. So, the things sometimes just do not go well, even if you have all the experience in the world. Now, talking about the AIs, the real world, how the world has changed after my giving one intravenous TPA for the first time, sort of in state of California in a community hospital setting, please. Okay, and now we are dependent on the AI to make a correct diagnosis. And it was surprising, after we did the retrospective data analysis study, to my knowledge, that 43% of the FDA clearance, which happened on all these devices, has no published validation anywhere. And then more important, which I came to know, that less than 20% of them had clinical evidence of clinical efficacy or really true clinical impact on our patient on day-to-day life, at least in publication. So there are over 100 commercially available products in AI in radiology for different fields. So one needs to be careful. We are clinical docs taking care of our patients. So we really need to really work very carefully as to how these gadgets and tools are helping us. That is the point I want to make here. So what about our study? DUEL, okay. I did not really coin this term, and there was no intention of this, but I read it to you. Detection of LVO using AI, evaluating RapidAI versus VisAI in detection of large vessel occlusion on CT angiogram. We have 1,591 consecutive cases, core stroke over 2 years. So let me tell you, you see, how this thing happened. I mean, I'm in a community hospital setting. We had rapid for years. We were one of the first hospital, in a community setting to have rapid imaging dating back to 2010, as I was mentioning to you earlier. In 22, our administration told us that we should also look at Viz. And then Viz was provided to us. And myself, being stroke director, our chief neuroradiologist, Dr. Kenneth Ong, and neuroradiology team, radiology department, our NIR team. Now we have 6 to 8 NIR doctors working with us, Dr. Reza Malik. So in our stroke meetings, which we do all our NIR meetings like twice a month, we all decided that, hey, we will use both the tools. We will use Viz and Rapid. And my take to my team, to all of them, my nurses, coordinators, everybody, that we're looking for LVO. We don't even care whether it's a Rapid or Viz, whatever AI. If we find LVO, that patient goes to the cath lab. You know what LVO means. LVO means that, large stroke. And that's how it started, basically. And then, years later, after it's done, that we said, okay, well, let's make the comparison retrospective data analysis. And the reason we did that, because we keep the qualification for comprehensive stroke center, there is a requirement to do research study and even retrospective study to keep the certification going. So this was, I thought, was a really great retrospective study approved by our IRB to really keep us going as a comprehensive stroke center. I'm sure you guys, many of you have comprehensive stroke centers, and you know all the requirements you're supposed to do for research protocols and research studies. Anyway, so coming to this quote-unquote study design, while we were doing it, there was no study design. We were just doing it, okay, as I mentioned earlier. So Rapid LVO and Viz LVO, all these AIs were installed in our radiology department. Dr. Kenneth Hong, who's a neuroradiologist, he's been with us over 20 years, from UCSF, has a great team. I mean, these things were installed by each company and were running simultaneously in both the imaging. And we had 1,591 cases over 2 years, as I mentioned. And now after we did the data analysis, I came to know we are one of the largest head-to-head consecutive study. I didn't even know that. And the most important thing, ladies and gentlemen, I want to make sure that we are not, quote unquote, totally AI dependent, okay? It's our radiologist. It's the neuroradiologist when he said, okay, or she said, hey, this is LVO. And that was a get-go for us. That was our gold standard. When our radiologist told us it's LVO positive, it's LVO positive. It's LVO negative, LVO negative. So that was our gold standard. That's how we went, in doing the clinical care of all our stroke patients at Good Samaritan Hospital. So I will go over the study numbers now. As I mentioned, we had over 1,591, consecutive stroke cases, just like from day one to the 48 months later. So over 2 years data we analyzed, and our inclusion criteria was ICA or M1 occlusion and high-grade stenosis. Our radiologist called high-grade stenosis was about 75% stenosis. So out of 1,591, 66 cases did not meet our inclusion criteria from the analysis point of view, from the study point of view. So when there was a poor bolus, we excluded those. There's a metal artifact, the ICH, because the treatment is only for ischemic stroke. We excluded those, and 33 were not processed, and there were a few others. And this is all depending on the radiology department. Why they were not processed, I do not know. Now, coming to the gold standard read, as I mentioned, it's our radiologists who were doing that, and they were turned to be LVO positive in 149 cases. I was myself a little surprised. I thought we'll have more, okay? So this is about 10% plus cases, and 1,376 were LVO negative. So you could see that the successfully processed cases by Rapid was 1,523, and by Viz it was 1,432. So out of 1,525, there were 2 cases which were not processed by Rapid, and 93 were not processed by Viz. And out of those 93, 84 turned out to be LVO negative, okay, but 9 were LVO positive as well. So this was all surprise. And as I mentioned earlier, ladies and gentlemen, when we were doing this, we were just looking at the patient, LVO positive, cath lab, okay. I didn't know which was telling me what, okay. And that was our most important thing to get go. So AI software evaluation, the real clinical impact. I mean, clinical decision is ours, right? And as I mentioned earlier, the AI detected 149 and 146 were positive with Rapid and 110 with Viz. And for the LVO negative cases where our radiologist said, well, there's no LVO, it's truly negative. So Rapid AI was 1,290 1297 cases, and Wiz was 1257. So the specificity from the negative point of view, Rapid was specific 94% of the cases and Wiz 91. But the LVO positive, for which, in my opinion, all this AI about, all our stroke care is all about, is not to miss a positive case. And that was 98% positive by Rapid and 74% by Wiz. And it's mentioned in this graph on the right side. That's the sensitivity part. I'll just show you some of the case examples here. Actually, we had a poster presentation at ISC in February this year, earlier in LA, and you could see the images on the Rapid on the left side and the Wiz eye on the left. And you could see the even perfusion deficit in these cases. And this is the second set of patients. These are chosen from our abstract as we were showing. You could see that we call the high-grade stenosis also as an LVO, so that those are the patient, even if they receive TNK, we took many of them to the cath lab as well, even if the TNK was given. And I have those numbers separately. So what is the message here? The message here is that 26% of the LVOs were missed by one of our AIs, which at that time, because we were just looking at whatever is positive, we just get go. So what does this mean to us, ladies and gentlemen? Our patient does not belong to be horizontal, staying like this the day they come in the gurney, in the ED. I'm looking at that patient with an stroke scale of 11 on 17, a moderately severe stroke. We need to do everything we're supposed to do, okay, for those patients. All kind of thrombolytic stent retrievers and the correct treatment, hypertension control, whatever we do as stroke docs, we're supposed to do. The reason is this: we want all these people to be walking, talking, and trying to live a normal life. And that's the stroke care is all about. You all know modified Rankin scale. I mean, I like to have all my patients have MRS of 0 or 1, okay? But not everybody, turns out to be like that. I show you my second case was not good enough, I mean, for whatever reason. And then we don't want the MRS of 5 or 6. What is the human cost? It's one human being which matters. Years of rehab, sense of self, job loss, depression, caregiver burden, all those things, you and me all know, we see it all the time. And then from the financial point of view, it was calculated that if one case is missed for LVO and just gets a routine treatment, not going to the cath lab, and that patient goes to rehab, the cost was like $15,000 during one hospitalization for a missed LVO. And that's not correct. We should be able to do whatever we're supposed to do. And AI is here to help us to make a clinical decision as what we do. So again, to emphasize, the sensitivity with RapidAI was 98% and 74% with Wiz. Specificity, the LVO negative was 94% with RapidAI and 91% with Wiz. And it is this, in my opinion, the sensitivity, the LVO being positive is the most important thing, which matters in the stroke care of stroke patients walking into our ED and all the stroke system we have set up here in Santa Clara County, a city of San Jose. And that's what it's all about. So the rapid LVO is showing consistently high accuracy. These are the orange bars. Hudson, this is our study, and Alison Hudson is my, neuroclinical care navigator, our top ICU nurse. I mean, she was the key in recognizing these cases and helping us. So we found that the accuracy of sensitivity with rapid in different studies was about 98, 97, 96, 6%. And the Wiz was 88, 82, 78. In our study, we had largest number of patients turned out to be 74%. And these are the numbers, which are there right in front of us. That's the only thing I'll speak of. Now, out of this large data set, and some of my colleagues have asked this question, what happened to our M1 and M2s? You see the MEVOs. We were at that time only looking for LVOs, ladies and gentlemen. We know we had cases with M1 and M2, and we are analyzing the data purely on MEVO now and in the process of submitting an abstract. But I'm not privy to disclose that. But the only thing I want to make sure to give you, not make sure, just to give my opinion, that CT perfusion imaging is much more valuable in vivo cases than we had even in the LVO cases. And we make decisions about who gets what treatment with our NIR doctors and stroke docs on clinical basis, case to case. It's always the case like that. So coming back to how we started, time is brain. We are the stroke docs who live by the clock, and AI tools are here to help us make a clinical diagnosis and treat. I just want to remind you that our first obligation is our patient in the ED lying on their gurney who is unable to move and talk and walk again. And a single life matters, ladies and gentlemen. And you know what makes our day? If that patient with 3 days or fourth day walk out of the hospital, and how many of our patients end up going to rehab? Of course, we help them as well. And so that's what this stroke care is all about. Any questions, Suhail?
Thank you, Dr. Sachdev. Now we will address a few questions that came in during the presentation. The first question is, how have the results from the study affected your clinical practice and outlook on AI technology in your hospital?
Well, my message is actually a little more succinct and clear to our stroke team and to my colleagues who are listening, that ultimately it is our responsibility. We are the clinicians, and the patient lying on the gurney with NI stroke scale of 13 or 15 or 18, moderate stroke, and the imaging is quote unquote iffy and not very clear, it's still you have to question that, you see. And the point is this, that even if it is showing that it may not be LVO in your mind, then you have to make your own clinical decision as whether you're going to take the patient to the cath lab. And none of the AI is perfect. Now I just want to show you the copy from the graph, which I didn't have in a slide. This slide, this is our abstract, which was presented as a poster in ISC meeting. You could see the last slide, the last patient here is shown where the Viz was positive, showing LVO positive, while the rapid was negative. So the point is this, Suhail, and ladies and gentlemen, none of this AI is perfect. Even rapid is 98%. There's still 2% of the patients were missed. And that's the point here. For all my colleagues, humbly, I want to share the experience that we have to be careful, you see. And whatever AI we use, we do not want to miss an LVO case. So we have to pay attention, go clinically, and also with the help of AI, make appropriate decisions.
Great. Next question is, how did you ensure the AI algorithms were optimally configured?
Well, I'm a clinical neurologist. Okay, I depended on Dr. Kanathong, our neuroradiologist, and his team of neuroradiologists, and our technologists in the CT room, and all the IT teams which are working with them, and they did all the configuration. I mean, we have been doing rapid for years, then we did Viz for 2 years in a row, and they were all installed by each company or our technical teams in the hospital. And Dr. Ong said that everything is hunky-dory, and it was so. I mean, how the configuration of each different AI was, I'm not involved with that. I was just involved with what I see and how I take care of the patients. So I presume that they were installed and worked as what it should be in the industry and in any other given hospital or university center even.
Great. After standard exclusions for ICH, artifact, etc., 93 cases for Viz were not processed versus 2 for rapid. Can you tell us why?
I don't have any clear answer for that. I'm not a physicist. I'm not a technical man. I'm not in engineering. I'm not a technical radiologist. So I cannot tell you how the software was configured or how it's done. I do not know. I'm unable to answer your question.
Great. Last question. What final advice would you give to stroke directors looking to expand their programs across the network with AI?
Well, I think we need to embrace AI, and there's no question. I mean, and work with this, and make sure we stay on top of this with all our neuroradiologists. our radiology team that are we looking at the things correctly? We now, after this data analysis, I'm being more concise and trying to be precise with our MEVOs. Okay, we don't want to miss the MEVOs and the perfusion deficit, and we're not trying to miss the even P1 or P2s or M1 or M2 occlusions. So that's the message, that pay more attention and question your neuroradiologist when they're looking at the imaging to be much more specific.
Great. That's all the questions we have. Dr. Sachdev, is there anything else you wanted to add?
Well, I just, want to invite everybody who's listening to this that, in a community hospital, which is a large community hospital in Silicon Valley, in San Jose. So, we are doing our 25th annual stroke update in a community hospital setting. And Stefan Meyer is going to be our keynote speaker. I just want to let you know that in our humble origin as a primary stroke center in this hospital, we started out with our keynote speaker or stroke updates. And our very first speaker was Jeffrey Saver himself. He was assistant clinical professor at UCLA at that time, helped me set up a TCD lab at Good Samaritan Hospital, one of the first one in the Bay Area. And so, this is a big event for us. We welcome everybody. This will be available on WebEx. And now Dr. Stefan Meyer is particularly going to talk about what is new in AI. So here you earlier asked what is new coming up. In addition to MEO is the ICH code stroke, which is coming up. And I understand different AIs, there's ICH module and hyperdensity modules available as well, and by different outfits. And we need to look into all that and embrace that. So this will be the new era of stroke taking, keeping this hemorrhagic stroke to the same level as we've done ischemic stroke over the years. So, ladies and gentlemen, you're most welcome to attend this on WebEx. If you happen to be in Bay Area, please do come to Good Samaritan Hospital. You have open invitation from me. Thank you.
Thank you, Dr. Sachdev, for sharing your invaluable insights with us. And thank you to everyone who joined us today in this engaging discussion. If you'd like to continue this conversation, please submit your information in the lower right box of your screen, and we will connect with you. And stay tuned and stay connected with RapidAI for the next Insights in AI virtual series. Thank you again, and have a wonderful evening.